Yeah, so I'm presenting on behalf of, that's fine, the Head and Neck Centre, which is obviously part of Liberal Health Partners, and the COVID Surge collaboration, which more of which will become obvious. Moving slides forwards, I'm sure that one will work. Yeah, so what I wanted to present on today was just some of the work we've done as part of a very large international collaborative about the interaction of surgery and COVID, and my involvement in head and neck cancer surgery, which has been a significant part of it. So just over a year ago, we had this chaos that happened to us, and ITUs full of really sick patients, cancer services in disarray, and we didn't know what to do for the best. We didn't know whether to worry for our patients' health, our health, whether to press on with cancer surgery, whether to cancel everything, whether to be redeployed to intensive care. We really didn't know what to do, and we had no data to go on. And all of our research stopped, all of our clinical trials stopped. So clinically, back on the ranch, I work up at Aintree Hospital. We have this problem, head and neck cancer, one of the biggest centers in the world. These rapidly growing tumors, some of them have to have primary surgery, and we had all our theatre lists stopped, and it was felt that there could be huge risks to giving patients general anesthetics, airway procedures, and tumors that could grow rapidly, let alone the risk to healthcare workers if we didn't understand PPE. So we had all of these opinions and worries, but no data. Trying to do clinical research was impossible because it takes years to do it. All these permissions and funding, it's all too difficult. You know, even just to get a trial open to understand outcomes would take a year. To actually do a really complicated trial can take the best part of a decade. But my colleagues in Birmingham University, as part of the Global Surgery Unit, were experts at doing international multi-center collaborative cohort studies, and they repurposed their entire NHR setup immediately, overnight, pivoted to collecting data on COVID and its interaction with surgery, with a number of sub-projects, one of which was on cancer surgery. So Anil Bangu led the cancer surgery part of it. I spoke to Anil really in the depths of uncertainty on the last week of March. We put an international head and neck cancer team together just informally with a network from the US, Australia, EORTC, etc. in a few days. And in fact, we opened the first center, which was Liverpool, on the 3rd of April, and we got other centers opened very quickly. And so the aims were to look in a range of surgery, in our case, head and neck cancer surgery, and to understand the safety for the patients and the surgical teams of continuing with head and neck cancer surgery. And we wanted to nominally pick the first 3 months of the pandemic between March and June 2020. So this was an international observational study collected on REDCap, no consent, anonymized data, 3 months worth of data, and we included all the head and neck cancer operations that we're doing, and we publicized it and exercised all our networks. So we picked people who were very well networked internationally in our specialty, and our outcome measures were severe pulmonary complications of COVID-19 for the patients, but we're also looking at COVID in healthcare workers that were operating on them, and a number of secondary outcome measures, the things you'd normally expect. And so I'm going to present data initially on the first 1,200 or so patients. In fact, we're now analyzing the whole cohort, and to get all the data presented and everything that was collected, prospectively, retrospectively, we collected data on about 5,000 head and neck cancer patients. So amongst these 1,100, we got early data for, these are the ones that were entered by the middle of April, and we had all the data by early June. We collect data from 26 countries, 133 hospitals. And in terms of just cutting straight to the outcomes, we found that 3% of patients were diagnosed with COVID within 30 days of their cancer surgery. Of those 3%, about 1 in 3, so 1% overall, got severe pneumonia. And of those, about 1 in 3 of those died. So the risk, if you have major head and neck cancer surgery, of dying of COVID is about 0.3%. So this was really quite reassuring, because that level of risk fits alongside some of our other operative risks, you know, the risk of heart attack, other chest infection, other severe negative outcomes. And this is in an era without testing, where PPE was dancing around, no vaccinations. So we know that we're safer than that now, but we did have some complications. So it was part of our consent. And so only a third of those developed severe complications, and about 1 in 10 of those who contracted COVID-19 under a GA died. And the complication profile of the patients otherwise was fairly much as expected. This associated in terms of the primary endpoint of pneumonia with advanced stage, node positive disease and people in intensive care, but actually not particularly with elderly patients or comorbidities, interestingly enough. So most of the surgeons who did these operations didn't get COVID, but 3% did. And what was interesting is that where the patient tested positive, 1 in 4 of the surgeons also tested positive. So head and neck surgery is a high risk profession. And in fact, the infection rate in head and neck surgeons is about 10 times their background community rates we were able to estimate. So this eventually got published. It got published. I'll talk a little bit about how we disseminate this knowledge, but eventually in Cancer, which is a reasonably high impact journal. And we were able to basically say that head and neck surgery was safe. And we should find the resource to do it where we understand how to make it safe and not worry unduly about the risk of COVID. If patients got cancer, that's their main risk. And we take the mitigations to try and make their treatment as safe as possible. And we produce these visual abstracts. So we try to get the whole information from the paper in a visual abstract. And we went mad with that on social media. And we got tens of thousands of views on Twitter for these nice visual abstracts that one of my colleagues produced. And we have this interesting concept of how we do this. So for this first paper, there are 850 authors, all PubMed citable. And we had a smaller writing team and stats team. But basically everybody gets equal billing on the paper. So the authorship of the paper is COVID Surge with an asterisk to a table online with all the authors. And this then, even for a reasonable journal like Cancer, turns out to be in their top 1% of outputs by impact, and a huge number of views. This was quite early on, and we'd had 215 tweets after a few days, and it was quite high up in these altimetric scores. And later on, we start to see in total in 2020 of all the COVID Surge projects, 190,000 patients recruited with 0 grant funding. This is pure collaborative effort. And it's very proud to say that we led in head and neck cancer side of things with 5,000 of those patients from Liverpool, but it's this broad collaborative effort. So we're going to follow that forwards, and we're analysing now the data on the 5,000 patients for the whole of that 3 month. And we really wanted to look whether the compromises that might have been made to treatment, omission of chemotherapy, de-escalation of surgery, for example, were going to impact on outcomes. So we did a little bit of fundraising, and we all did a Land's End to John O'Groats virtually in August 1st last year. And there's me doing a 100-mile time trial, and we all did different things and raised a bit of money to employ statisticians and to get a little bit extra funding. So moving the clock forwards, by the autumn, it was obvious we were going back into problems. And Chris Whitty said, we're going to see real problems this winter. And we were hoping the NHS would prepare better. The second surge was widely predicted, but how well did we do? And what we thought we would do is activate the network and find out. So we did a capacity survey. And again, we launched this survey in the first week of February. We did a data lock on the 8th of February, and for the UK data, we were able to publish the data 3 days later, pre-peer review. And what we found was actually a little bit distressing. From a RedCap survey, we got data from 62 of the 64 UK hospitals that were doing head and neck cancer surgery. And in every region, there were units doing no surgery because they had no capacity, and units with 100% capacity that they could have taken the cases, but there was no system to distribute the patients. So there was no system that had both the authority and the information to reorganize cancer care in a way that was logical, bearing in mind intensive care pressures. And most patients were having their treatment compromised. A minority units had more capacity than normal because they'd cancelled all their electives and they'd actually got resource they could have used. So this mismatch between capacity and demand didn't work out well for our patients in February this year. And that's disappointing, and it's interesting. It's just an area the National Health Service wasn't behaving well nationally. But again, we got a nice visual abstract. Hopefully that works for you. And we did a video one this time about have we learned the lessons from the first wave. This just plays over 30 seconds or so. And I say we got huge response. Almost every head and neck cancer centre in the UK responded. And our referrals were back up towards normal. We were up to about 80% of pre-pandemic levels. And our capacity, if anything, was even less than the first wave. Staff were drawn into intensive care from theatres and the wards. And treatment compromises, either de-escalation, change in treatment or delay for 50%. So you make your own conclusions whether we learn the lessons properly as a national health service. And interestingly, we're now looking at the international data, about to publish that, and what we found is, as you'd expect, the income level is this a disparity in engagement with testing, with staff testing, with PPE, and particularly vaccination. And I think it's a big global political issue, but we're doing things actually quite well now in the UK and other developed countries, and in low and low middle income countries, they have been left on their own and they don't have the resources we have to do surgery safely. So that's the head and neck stuff, just a brief overview. I'm just going to literally one slide each on a few other of the main findings. This was a paper we produced in the Journal of Clinical Oncology with all the cancer surgery together, proving that if you have COVID-free surgical pathways, you can halve your risk of COVID and halve the risk of death post-operatively. And that's what we need, is either cold hospitals or cold pathways. And this was a paper in the Lancet from last summer, same authorship. And basically we looked at the risk of COVID in surgical patients. And what we find is that 50% of patients having surgery with COVID have severe pulmonary complications, and the mortality rate is over a third. So surgery is to be avoided. How long should you leave it? So this was the outcome of a study called COVID Surge Week in October last year. And there's a crystal clear answer from 140,000 patients. This paper has 15,000 authors. And what we found is you need to leave it 7 weeks. If you operate on patients before 7 weeks, they have a higher risk of death and pulmonary complications. If you leave it to 7 weeks after COVID, their risk returns to baseline. Very clear answer from an observational study. And these are all the papers. And so there's about 15 papers there, and they're getting highly cited and in some good journals. And one of the things that's interesting is that we have broken Scopus, we've broken SkyVal. For those people in the University of Liverpool think that they can assess my research impact by measuring my SkyVal or Scopus, you can't. We've broken the system. So, you know, we shouldn't be naive and think we can quickly assess university professors' output by the traditional means. The world has changed in terms of collaborative research. I think I'm about there, and I've gone 1 minute over. I do apologize.
Thanks, Richard.
That was a great talk. Thank you, Richard. Lots of really rich content there. So please do put questions in the box for Richard, who may have to leave us due to clinical commitment. So if it's okay, Richard, if there are any specific questions for you, we may be in touch afterwards, and then we can share those with the group. Because I guess the trick is, that's a great example of team science, and the trick is figuring out what becomes business as usual, so that we don't lose that learning. So thank you so much for your time.
Thanks, Dawn. Thanks for your help.
Okay. Well, you're welcome. So next up, we have one of our newest programs, which is neuroscience and mental health. And we have our program manager, Jade Tai, and I believe we've got Connor Malucci joining you, Jade. No, we're going to, oh, you haven't? Is it just you? Are you soloing on this, Jade?
Yes, I'm afraid so. Connor has personal reasons. He apologizes.
No worries. So you feel the pressure, but we're all behind you. And we're really excited about this this particular theme, because we've got clear clinical excellence. We haven't got a strong academic track record, but that's not stopping us really figuring out how we make a difference for our patients and move towards the academic strength. So Jade, over to you.
Thank you, Dawn. So as Dawn said, the program is the youngest of the LHP research programs, and the program director is Professor Connor Malucci, who is a consultant pediatric neurosurgeon at the Alder Hey. And I joined the LHP family in January of this year to work with Connor as the program manager. And we're currently in our scoping and development phase. Sorry. So to do this, we have in the last 12 months, and the 3 months I've been here, LHP, as you know, is set up to enable systems working and nurture research collaborations across our NHS and HEI partners. So the program has started to scope and develop resources to identify and support our key research objectives and themes, to establish future research projects and programs. And we are working closely with our other research programs, starting well, infection, cardiovascular and cancer. And we've already established some cross-cutting core research themes together, which I will be introducing in later slides. But to do this, we wanted to use research support resources to help, and this has been through research workshops, networks and special interest groups, such as the Mental Health Research Collaborative and a neuroimaging special interest group that will help across many projects that will have neuroimaging components, and a brain injury group that is collaborating and creating programs across our lifespan, pain research, which is encompassing our whole life course from starting well, living well, across to aging well, stroke and neurovascular, neuro-oncology group, child neurodevelopmental group, and in collaboration with our cardiovascular program, a cardiovascular disease and mental health group, and between the Liverpool Women's Hospital and our higher education institutes and neonatal neuroscience group. And all these groups are open for membership. So if anybody has a research interest, please contact me to join the groups and support further new research projects and ideas. So one of our platform things that we are developing is a neuroscience bioresource from conversations across the members of our groups and our partners. So we've started a small working group that is growing in order to look at how we can develop this. And the working group is looking at the business planning and funding for a neuroscience bioresource, and the staffing and resource levels with technical support required, from lab technician support to research nurses to identify patients and consenting. And of course, the governance structure will be key to establishing a neuroscience bioresource. And we're lucky that the Walton Centre has an excellent governance model that we're hoping to expand. And because their governance model allows their biobank to be completely embedded within the patient pathway, which is how the research should happen. And then, so we're looking at timescales for implementing a neuroscience bioresource that will have tissue samples, but also radiological examinations, CT scans, MRI scans. So all of this needs to be worked out within our working group. And of course, what's really important is the sustainability model and planning for this. So how do we adopt funded research into the neuroscience biobank? How do we use the resources available to us? And we've been in conversations with the Clinical Research Network of Northwest Coast to look at how portfolio studies that are going to be inputting into this bioresource will be supported by the CRN in the form of service support costs. So a lot of work to be done. We're in our early stages. So here are some of the key research themes that we have identified and we're already working on. So brain injury is a major research theme we're working on. And this is working across many of our partners. So the Unicorn program is understanding neurological brain injury in children, measuring outcomes, impact of research, and neurorehabilitation. We're looking at blood biomarkers of brain injury in children to improve diagnosis and predict longer-term cognitive mental health outcomes. This will link across to our brain research and intervention network, BRAIN, in which is a group that is developing research on new models of care and interventions for brain injury from childhood to adults. And this is a collaboration between Alder Hey, Walton Centre and Mersey Care. And of course, there is also the Liverpool Centre for Alcohol Research, where we're looking at the alcohol-related brain injury. So, and another research theme, perinatal neuroscience, we are working with Francis McClone, who I think is in the audience today, on his C-Touch project in collaboration with Elaine Neary and at the Liverpool Women's Hospital. And we're hoping the application for a neurodevelopmental prototype of his C-Touch intelligent mattress, which is hypothesized to have long-term neurodevelopmental and mental health benefits for preterm infants. And we're also developing a research theme in neurodevelopment and deprivation. So low socioeconomic status is associated with a higher probability of multiple exposures, such as neighborhood violence, poor nutrition, housing instability, air pollution, insensitive caregiving, known to have an effect on the structural part regions of our brain. And so deprivation will have a huge impact on neurodevelopment and is a new research theme that we are jointly doing with our Starting Well program. Chronic pain. This will have a number of research programs currently in development to focus on chronic pain based on the identification of new targets in the brain for intervention of pain management treatments and therapies that is common across a range of neurological and psychiatric disorders. But we're also extending this to women's health in collaboration with the Liverpool Women's Hospital, looking at pelvic pain as well. So we are capitalizing on the strengths in the region already established, such as the strengths of the Walton Centre and Alder Hey for neurosurgical clinical trials, which has attracted over £10 million of research funding with our programme director, Conor Malucci, Michael Jenkinson and Professor Willoughby. Beyond the neurosurgical clinical trials, we're also working on core outcomes in neurosurgery and neuro-oncology with Paula Williamson. So infection research, of course, is a major strength in the region. We're working closely with our infection program, and we are focusing on brain infection and bringing together the academic and clinical strengths across our partners to create new research collaborations and projects to advance our scientific understanding and clinical care. Ooh, I've gone too far forward. Epilepsy. So of course, another strength in the region and at the Walton Centre, and we are working closely with the clinicians there to use multidisciplinary research approaches, bringing together the statisticians and the epidemiologists in our university to strengthen the research connections across our partners from pediatric to adult research themes in epilepsy. In development at the moment are a number of other we're in the early stages and we're just setting up research workshops and the network for these additional themes, which is movement disorders, neurodegenerative diseases, neuroinflammation, and chronic fatigue. Particularly our chronic fatigue team, we're already putting them together, and we're going to be setting up a program to look at the neurosubstrates of chronic fatigue, but also fatigue management programs and comparing patients with multiple sclerosis, chronic fatigue syndrome, long COVID, brain injury, and cancer. So for the mental health research, this is a very challenging space at the moment, but we have identified some early themes that we're already working on. And so neurorehabilitation and mental health is linked to our unicorn program that I mentioned in the brain injury and the brain rehab intervention network. This theme will focus on interventions and mental health benefits of brain injury treatments and therapies. I mentioned also before the perinatal neuroscience is linked also with our mental health because we hypothesize that there'll be long-term mental health benefits. Francis's work has shown that the C-Touch stimulation can confer resilience against adversity and stress. Digital mental health is linked to the innovation arm of our research strengths of Mersey Care Trust. Art therapy and mental health is capitalizing on the success and formation of the Research Centre for Art and Wellbeing at Edge Hill, with collaborations with Mersey Care and Luft using art therapy in NHS staff and in vulnerable patient groups, with the neuroscience bringing the evidence-based research showing the neuroprotectiveness and benefits of art therapy. And of course, we have to look at the comorbidity between mental health and physical disorders. which we are working very closely with the ARC on this. Now, our mental health research collaborative group, which identified in their last meeting that they wanted to focus on 2 key priorities, which was suicide prevention and self-harm, and the impact of COVID pandemic on children and young people's mental health. Therefore, in our next meeting, which will be next Friday, we are focusing on this theme, and it's at 2 o'clock. If you would like to attend, please contact the LHP admin email, and they will be able to send you an invitation to this meeting. So the membership of this group is very large. It's not just our 12 partners, but also NHS trusts and universities across the Northwest region, and which was started by our by Mark Jackson. And this 4th meeting, we've got confirmed invited speakers is Ms. Sian York, who is a deputy head teacher from Coldeston Secondary School, and she will be sharing their experience at their school on the impact of the restrictions and the pandemic on staff and students. And then from the Liverpool John Moore University, Dr. Emma Ashworth will be presenting her Alice and Tell study, which is surveying the impact of lockdown on teenagers in the city. And then we've invited Oba Akinwale, a director of operations from Loudspeaker, which is an organization that's been delivering workshops to young people with an aim to help improve their ability to speak well and confidence building to take opportunities to enable social mobility and long-term success. And he will share how they've had to go online, but still reach out to this group.
We're at time now, Jane.
Yeah, I am at the end of the presentation. Thank you very much. And as I said before, please do get in touch with us and because we're still in the early scoping and development phase, and we would love to hear from you. Thank you.
Thank you, Jada. You did that flawlessly without your program director. And this is an early exciting theme for us, and it's been great to be able to work with the Walton Centre on this, and I'm delighted Janet Ross, the chair of Walton Centre, has joined the call today, and of course the CRN, and we have Enid and Carol as clinical director, because this really is about a team approach. So thank you to Walton Centre and CRN, and thank you, Jade. So given that we've got most of the people who've shared their weekend plans in the beer garden, it's quite apt now to move on to our next and final speaker around alcohol injury. So Lynn, over to you.
Can I ask to go first? It's just that I'm in the middle of something else, please.
Of course.
Thank you.
Of course. Is that all right? Yeah. Okay. Off you go, Paul.
Sorry, Lynn.
Okay.
Let me see. I've only got a few. Sorry, my name's Paul Richardson. I'm a liver consultant at Luft, and I've just got a few slides to share with you when I can work out how the bloody hell to do it. Is that? Can you see this or not? Yeah. Okay, so any of you living around these parts, and certainly any of you who've done any clinical work around these parts, may have come to the conclusion that alcohol's a bit of a problem, and you'd be right. So Liverpool and the Northwest in particular, huge amounts of alcohol-related harm, whether it's and huge burdens to our healthcare system, both in relation to alcohol admissions and alcohol-related end organ damage, particular liver disease. So the vast majority of patients we see with the complications of cirrhosis, so cancer, liver failure, is all due directly to alcohol. And unfortunately, it's also an area which seems to act worse on areas of deprivation, which, you know, if you look at Cheshire and Merseyside, certainly has some of the highest wards of deprivation across the country. And that, I think, was recognised by the NIHR when they put out a liver call, seems so long ago, at least 2 years ago now, I think, about looking for studies looking at alcohol and liver disease in particular. And this has also been matched by the James Lind Alliance, which is a charity and a focus group which has highlighted areas of under-research, and their number one target was how do we stop people who have liver disease from drinking to improve their outcomes. And sorry. And it's just a very schematic, very quick. So this is my job, my day job, basically stopping people you see at the top, the fatty liver that you get ubiquitously with heavy alcohol consumption, leading to cirrhosis, irreversible scarring, and the consequences: liver cancer, liver failure, requirements for transplant, etc. And there's near enough a direct relation to the amount of alcohol you use. There's very little in the literature around progression from milder forms to more severe forms, but there is a good deal of literature showing outcomes associated with people who've already had cirrhosis. And essentially, to put it in a nutshell, if you don't stop drinking, you don't do very well. And also the continuation of drinking, apart from you're not doing very well, also precludes you ever being a candidate for transplantation. So you would think in the burden of disease and the fact that you know, it's a huge burden to NHS, etc., as well as, you know, as an individual level, that would be rich in the literature about trials to stop people drinking once they have cirrhosis. So this is the only randomized controlled trial in the world literature in that setting, and as you can see, it's from a wee while ago. And this is a trial of baclofen. It was for 3 months, which showed that baclofen was superior to placebo for people to remain abstinent at 12 weeks. So, and I won't bore you with all the other, but the literature around baclofen is too heterogeneous to really judge any meaningful conclusions. And probably the only meaningful conclusion you can draw is that there needs to be more properly designed clinical trials, and that's what I'm here just to mention now. So we were successful from HTA funding from that liver call for 1.6 million grants. Myself and Professor Pir Mohammed are the co-chief investigators, and we're looking at a patient group which has just confirmed cirrhosis. There's 4 arms of the study, 3 doses of baclofen for 6 months and a placebo arm, and we're randomizing 100 to each arm. These are patients who've expressed that they want to stop drinking. So these are not patients who have no interest in stopping drinking. One of the areas that we need to explore in more detail is around dosing and also blood levels and their impact on patient effectiveness, and that's one of the major thrusts of the study, as well as some pharmacogenetics, as there's some data coming through that polymorphisms in the GABA B receptor may influence quite dramatically your response to baclofen. The primary endpoint is abstinence, because basically, as I've shown you, if you don't stop drinking, you don't do very well. And some secondary endpoints around liver function, drinking, other drinking measures, and also some craving and anxiety. So we're setting up the study at the moment. So we're due to start recruiting early next year, and I thank you for your attention.
Okay, thank you, Paul. Please put questions in the chats for other speakers, and then over to you, Lynn, please. I think,
Paul,
can you?
Please, Paul.
I'm trying. It's stop share. There you go. Thank you. Sorry about that.
Sorry. Is that sharing?
No.
Not
No.
yet.
There we go.
Thank you.
Yeah. Okay then. So I'm just going to very, very quickly, hopefully in 5 minutes, tell you about the other form of end organ damage that we see in our patient group, and that's alcohol-related brain injury. We're coming very much from a clinical perspective here, and it's really important for us to highlight what we don't know, which is a fair bit. I think it's important to say that the prevalence, or the estimated prevalence, is probably an underestimate, because we don't really have agreed algorithms for how to assess for the presence of alcohol-related brain injury. The most commonly used definitions at present are under the DSM-4, but these have been shown to be vague, subjective, and certainly have poor clinical utility in acute care settings. One of the most important things and what drives us to continue with this work is that we know that with sustained abstinence, this condition is reversible, probably in about a third of patients. We don't yet know what the best approach is to screening, identification and diagnosis, and we don't know what the best approach is to treatment and support. So that's what's driven us. So I'm just going to take you very quickly through our journey. It started with some funding from the Health Foundation, where we developed a screening program that helped us identify patients and then better categorize the patients in terms of their problems, their healthcare utility, the support mechanisms around the patient, so that we better understood what this patient cohort looked like. We then followed these patients and got a lot more information about how their journey changed and whether recognizing alcohol-related brain injury was a useful thing to do. And we had some confidence with some early results to say that we helped about a third of patients to remain totally abstinent, that retention rates in this patient group, which are traditionally very poor, were improved with about 70% remaining in treatment for 3 months. We saw a significant reduction in the amount of hospital admissions and attendances from this group, which has a potential for savings. Perhaps most importantly, the reports we got back from families and carers were that the value of the assessment and the diagnosis in looking forward and ensuring that patients got appropriate targeted treatment. We then looked at our own clinical area to try and estimate some period prevalence, which of course came out a lot higher than what's reported in population prevalence. We are currently undertaking a systematic review, and the aim of that review is to investigate how others internationally are defining alcohol-related brain injury, both for diagnostic purposes and for referral purposes. And that work will inform what we intend to do in terms of developing a consensus definition for alcohol-related brain injury. We've been successful in getting some funding from the Oglesby Foundation to actually implement a care pathway. What we've not yet been successful in doing is getting any funding to ensure that that pathway is robustly evaluated and that we can gain as much useful information from that pathway as possible. So that's an ongoing concern of ours. The next steps LCAR will host the working group to develop the international consensus for definition of ARBI, and the results of our systematic review will be utilised to inform that process. I see Debbie Partington's on the call, and her group in the Innovation Agency, the PIES group, have been absolutely instrumental throughout in supporting us with this work from a patient perspective, and we hope to strengthen that further. And we have had 2 unsuccessful NIHR bids to look at this whole problem and try and devise strategies to identify alcohol-related brain injury. And we feel that once we have the consensus definition, this will help us look at those bids again. And we certainly today have a plea for anyone here to come along and help us and support us to get this research going. Thanks very much.
Thank you, Lynn, and both Lynn and Paul, beautifully on time, which has helped us enormously. So thank you for that. We have had a number of questions in the chat throughout, and I think Elizabeth is going to pull some together because we have our speakers. We'll have a short, good, decent enough chunk of time for questions and answers, albeit we have lost Richard Shaw to a clinical complication. So Elizabeth, what have you seen in the questions? Are you able to group them together for our speakers?
I am indeed. Thanks so much, everyone, for the questions. It's really great to receive them. And one of the first questions we received, and it was for Richard originally, but I think it applies to all our speakers today, is that what will you take forward as business as usual following COVID? Who would like to take that first?
So we start with the easy question.
Yeah. Lynn, would you like to take that one first?
Yeah, I'll take that. I think, particularly for alcohol treatment, we've always been very cautious about how we offer pharmacological management for acute withdrawal. And COVID forced us to design some really innovative pathways in terms of patient follow-up. So although assessment we can't get past doing face-to-face, actually some of the follow-up has been really successful face-to-face, and we'll certainly be utilising those models going forward. We won't be going back to 32 patients on a clinic on a Monday morning. So it has been, and it's given us the confidence, you know, to test those pathways and those protocols. So if there's been a good outcome for COVID, can we claim that one?
I think confidence is really interesting, Lynn, isn't it? Because when it gave us no option other than to try different things, which I'm sure would have taken us literally decades had we not had the so-called burning platform. Thank you.
Thank you, Lynn. Another question again for both of our speakers that are still with us has been that mental health has been a major issue that's emerged from the pandemic. Are you seeing this reflected in the funding opportunities that are available?
Well, I have just attended a webinar this week with the Wellcome Trust about their new funding streams. And for Discovery Science, mental health is one of their main themes. It will be mental health, global warming, and infectious diseases. So you can see how the pandemic has aligned their priorities for research funding in their new structure already. And certainly there's been some very imaginative working that I've already seen across us, our partners and particularly with Mersey Care, we're surveying the staff at the moment to identify the research priorities in mental health that have been impacted by the pandemic and physical health of conditions that have been impacted. So I think funding wise, it's more about, you know, where we are showing that we are going to make a difference, where we are addressing those key priorities that is the same as usual before the pandemic, but the lens of the pandemic can't be ignored, obviously.
Thanks so much, Jade. That's really helpful. Is it the same for you, Lynn?
Not really, no. I think, obviously addiction is part of the mental health theme. So that, you know, as a whole sort of addictions research, but not necessarily around alcohol treatment or alcohol interventions, or not yet anyway.
Thanks so much, Lynn. We've got a question again, which has relevance to both members of the panel. It's come from Janet Rosser, which is for both of you. Is your work plugged into the prevention and the public health agenda? We start with Lynn.
Absolutely. And we're very lucky to have Dr. Richardson as a chair of the SDP. So his work is very much focused around development of integrated care systems, the whole public health agenda. I do a lot of work with Public Health England and NHS England on alcohol clinical pathways, education, training. So we are very, very much plugged into the public health networks.
Thank you so much. And Jade?
Well, I've only joined in the last 4 months, but we are very much plugged in because LHP has already got the strong connections, which I'm benefiting from in my program to further develop, and it has been full pelt since January, but that's fantastic. I've enjoyed every day and meeting all my new colleagues, and so absolutely the public health aspect Connor and I are working on, and in fact we're having meetings this afternoon to develop that aspect in terms of both neuroscience and mental health.
Oh, wonderful. Thank you both very much. So we've got another question that's relevant to both, and it comes from Mark Jackson from LHP, and it's that the principal consequence of alcohol-related brain injury seems to be cognitive impairment. How do you differentiate the effects of alcohol versus other issues such as the onset of dementia or other mental health issues?
I'll take that first, because from a clinical perspective, we have to have a very pragmatic approach. So I'm sure our neuroscience colleagues will be able to do a lot of very sophisticated screening. What we need to do is be able to differentiate very early. So we're talking about in emergency departments. So what we tend to use is in the absence of. So if you've had a head injury, you will get a CT of your head, and we can exclude brain or trauma. We are, well used to assessing for hepatic encephalopathies and everything that goes with that. In terms of other dementias, we have to rely on clinical notes. But what is really important to point out is that from our perspective clinically, this is a very, very much a staged approach. So it's identifying patients who are at risk of or have potential for. And we understand that if we get those patients and then refer them for appropriate full psychoneuro assessment, then we'll get an accurate diagnosis. What happens currently is they don't get any of it. So it's about, and it's also about not raising awareness of alcohol-related brain injury, and then Jade getting 236 referrals a month. We have to have a way of screening and making sure that referrals are appropriate.
Thank you so much. Do you have anything to add, Jade?
Well, that's what Lynn was saying, obviously we want to work with LCAR, and brain injury is a massive theme in our programme. And it will take a multidisciplinary approach, whether it be for the research side, but as well as Lynn's just highlighted in the clinical side. And this is exactly what LHP should be doing, is that system level working, bringing that multidisciplinary approach to tackling important healthcare problems and hopefully improving patient pathways.
Thanks so much. You will have seen in the chat that we've had some colleagues who are attending today reaching out for collaboration, and there's been suggestions, for example, about collaboration with CAMS as well. So it's really positive, and I think that we can all say that we're of one mind on this call around engagement and collaboration being so important. If I've not had an opportunity to get to a question that anybody's raised, I'll follow it up with our speakers afterwards and come back to you on email.
Yes, I see from the chat, Kate and Abby, I will be absolutely contacting you by email, and we'll talk about the work that we're currently doing and more work we should be doing with the CAMS partnership.
Thank thank you for that, and thank you for the question and answer session. It's really, it's really interesting, isn't it, that COVID, some of the positive elements of COVID around how we allow us to interact like this, and but there is an interesting balance with the face-to-face contact, though, isn't there? So Elizabeth shared with me an article from Susanna Walker, who is from Liverpool John Moores and is on the call today, and it is interesting looking at the impact of the COVID restrictions on our well-being and loneliness and distress. And in fact, we've evolved over millions of years to have direct and physical contact with one another, which looks like some of our attendees in the beer garden will start to be able to get over this weekend. But I think the really interesting and exciting thing from our point of view is that actually, regardless of that, COVID has enabled us to leapfrog in some of some of the things that Richard was talking around, our team science and collaboration you wouldn't have believed were possible, and also all the other speakers have talked about collaboration as being the important way forward, and I think that is really critical, because even back in the days when Deming was a prolific figure in improvement and management worlds, he talked about has been thwarted by our best efforts if we aren't careful to collaborate and align. And I think what we've spent this last hour thinking about is how we do that to some great effect for our patients. So it really has reignited the excitement for me around the importance of team science and collaboration. So thank you so much to our speakers and for our audience in asking such questions. We will be running a series of these quarterly going forward, so please do feedback to us. Elizabeth has sent the SurveyMonkey link round, and I warn you, she will mercilessly hound you until you complete it, so please do complete it. And let's hope the sun lasts for the beer garden adventures this weekend. So thanks so much once again. See you all hopefully physically soon in person.
Thanks, Dawn.
Bye bye.